Hello again, everybody, and welcome back to the second iteration of the Scientific Advisory Board session of oral presentations. We have another 4 truly outstanding presentations in store for the next hour, science by junior members of our field that is really cutting edge and I think lets us look forward to a fantastic future. It's my pleasure to get us started with the presentation by Dr. Aiman Suleiman, who won the Resident Fellow Travel Award this year. Unfortunately, no travel, but still congratulations on that award and your fantastic work. Dr. Suleiman is at Beth Israel and will present on the effect of tidal volume on postoperative respiratory complications. Please take it away.
Hi, my name is Aiman Suleiman. I'm going to talk about how the association of tidal volume and postoperative respiratory complications is modified by patients' respiratory system elastance. I have no conflicts to declare. Stress from high pressures and strain from high tidal volumes during intraoperative mechanical ventilation are important drivers of postoperative respiratory complications. However, there is conflicting evidence with regard to the effect of high tidal volumes during intraoperative mechanical ventilation. Recently, it has been proposed that in patients suffering from the acute respiratory distress syndrome, the effect of high versus low tidal volumes on patient mortality is dependent on the respiratory system elastance. In this study, higher tidal volumes were more harmful if the patient had a high elastance or low compliance. This could explain equivocal results from studies in the intraoperative setting. However, compared to patients with ARDS, surgical patients typically have fundamentally different respiratory mechanics. In our study, we investigated whether the association between tidal volume and postoperative respiratory complications varies with patients' respiratory system elastance in the surgical population. Elastance, the reciprocal of compliance, is defined as the pressure required to inflate the lungs. Compliance is the tidal volume over driving pressure, and when we say standardized, it means it's normalized to the ideal body weight. So what did we do? In this retrospective analysis, we included surgical cases performed between 2006 and 2018 at 2 competing healthcare networks in Massachusetts. We excluded patients with ASA more than or equal 5 and patients who underwent surgery that was emergency, laparoscopic surgery, or microlaryngoscopy. The primary exposure variable was defined as the interaction between tidal volume per kilogram ideal body weight, categorized into high, more than 8 ml per kilogram, or low, less than or equal to 8 ml per kilogram, and standardized respiratory system elastance. Primary outcome was respiratory failure, defined as either re-intubation within 7 days, post-operatively, or post-extubation desaturation below 90% within the first 10 minutes after extubation. In the primary analysis, we applied multivariable logistic regression with the interaction term analysis to investigate if the association between the use of high versus low tidal volumes and postoperative respiratory complications depended on patients' respiratory system elastance. In our secondary analysis, we tested how much of the tidal volume effect is mediated by driving pressure. We chose this analysis because the driving pressure is the result of interaction between tidal volume and the individual patient's elastance, and compared to elastance, it can easily be measured in the OR after tidal volume has been set. Nearly 200,000 cases were included and 11,000 patients suffered from postoperative respiratory complications. The median standardized elastance was higher in patients with the complications. It was 1.92 versus 1.76. The association between high tidal volumes and postoperative respiratory complications was significantly modified by standardized respiratory system elastance. So let's look at the first figure. In the high tidal volume group, in the maroon color, the adjusted risk increase and the odds ratio of postoperative respiratory complications was 1.42 per increase of elastance by 1. By contrast, in the low tidal volume group, which is the navy line, the increase in the odds of postoperative respiratory complications was lower with an adjusted odds ratio of 1.21. This was reflected in the adjusted excess risk of postoperative respiratory complications associated with higher tidal volumes. If we look at the second figure, we see that we identified 3 areas of interest. The red shaded area, where standardized elastance is higher than 1.65, depicting a low compliance. High tidal volumes were associated with significantly higher risk than lower tidal volumes. However, no significant difference between high and low tidal volumes was found in the blue shaded area, where elastance ranges between 0.8 and 1.65. depicting a moderate compliance. Interestingly, we found an area where a lower risk of postoperative respiratory complications by using higher tidal volumes compared to low tidal volumes was observed in patients where the standardized elastance is lower than 0.8, which depicts a very high compliance. This, however, only affected very few of our patients. In our secondary analysis, higher driving pressures were associated with an increased risk of postoperative respiratory complications, adjusted odds ratio of 1.04 per each 1 centimeter water increase. The Beth mediation analysis revealed that the adverse effects of high tidal volume were completely mediated by increasing driving pressure. Finally, in an exploratory analysis, we found that the driving pressure associated with the average risk in the general study population was 14.1 centimeter water, and exceeding this threshold increased the predicted risk of postoperative respiratory complications. To ensure better fit over the tails, we used fractional polynomial analysis. In the second figure, results remained robust and with slightly better estimation at extreme values of driving pressure. The messages that I would like you to take home today: the effects of tidal volume on postoperative respiratory complications depends on patient's respiratory system elastance. Physicians should consider assessing the patient's lung mechanics and apply tidal volumes accordingly, with the goal to limit the application of high driving pressure. Future studies need to investigate potential harmful effects of low tidal volumes in patients with very low elastance. Thank you very much. I'm looking forward to your questions.
Thank you so much. That was fantastic. As always, audience members, please ask your questions in the chat. There is, I think there are two chats, both in the platform and in the Zoom session, and feel free to use either of the two. And while everybody's typing, Dr. Suleiman, how did you choose the respiratory complications that you looked at in this study?
Thank you so much. This is an excellent question. We used an outcome that is a composite of hard measures that were retrieved from multiple entries to our system about the patients in our records, and of course have been justified previously in other studies. But to address other concerns in regard to other definitions of postoperative respiratory complications, we also conducted an effect modification analysis on a broader definition of postoperative respiratory complications, including atelectasis, pneumonia, and exacerbation of previous pulmonary diseases. And our results remained robust, with significant effect modification by elastance over tidal volume association with postoperative respiratory complications.
Excellent, thank you. It's always difficult or impossible to infer causality from this type of study. But do you think, is it just quote unquote the tidal volumes and the driving pressure, or is the choice of an elevated tidal volume and a high driving pressure, is that a marker of a certain type of case, a certain type of anesthesiologist, a certain approach to practice? Meaning, is the ventilation parameter truly the cause, or is this just one marker of a slightly different approach to the patient?
Thank you so much. That's also an excellent question. Of course, as you know, elastance can be affected by many and multiple factors. And one of the factors, as you suggested, is the type of surgery and also the provider. For the type of surgery, for example, in our primary model, we confounded for multiple types of surgical services to try to decrease the bias that would result from the type of surgery itself, because we know that some types of surgeries will dramatically affect the calculated value of elastance. And we also, in our exclusion criteria, we excluded emergency surgeries and laparoscopic and microlaryngoscopies. And then we conducted also a subgroup analysis in patients with thoracic surgeries, and all throughout our results were remained robust. For the provider variability, I agree with you that the intraoperative management of mechanical ventilation also depends on the anesthesia provider practice and preference, and that's why in a sensitivity analysis we conducted, we assessed the provider variability in giving high tidal volumes. We conducted a multivariable mixed effect logistic regression model for the anesthesia provider, and we included the anesthesia provider as a random effect. And for each anesthesia provider, we calculated the adjusted likelihood of using high tidal volumes over the cases, of course, performed by each provider. And our primary analysis remained robust throughout this analysis. The effect modification of elastance over the high tidal volume association with postoperative respiratory complication was significant.
So it's more a patient effect than a provider effect. Okay, that's great. You mentioned you also looked at atelectasis as another outcome. Just out of curiosity, how did you assess atelectasis?
So it was based on ICD codes and doctor's notes. We could retrieve the notes that say that the patients had elastance, that the patient had atelectasis, and based on that we confirmed.
Okay, that makes sense. Where are you taking this next? Is this ready to influence practice, do you think?
So yeah, definitely. I think there is a clear message for clinicians here. Our findings support the concept of individualization of mechanical ventilation, even in patients with healthy lungs. The results also support that ventilation with lower tidal volumes are beneficiary in nearly 60% of patients, and at least we could say that they are safe in most patients. Of course, as I said also in the presentation, it might be harmful in a specific group of patients where the compliance might be very high, but those were small group of patients. The interaction between tidal volume and elastance also is reflected by driving pressure, which is we think is clinically intuitive for clinicians, and we could measure it directly in the OR, and that's why we conducted a mediation analysis as our secondary analysis. We also estimated the average risk of postoperative respiratory complications in the population of patients that we had, and it was related to driving pressure of 14.1 centimeter water, and that's why we can say the study is really carries relevant information and could be really important for the design of the future prospective studies, and can help develop strategies in individualized mechanical ventilation, if that's correct, based on the respiratory system elastance.
Excellent, thank you, very helpful. Are there any questions from the audience? I don't see any. I was also intrigued really by your finding that of the subpopulation of patients who were harmed by the lower tidal volume, or appear to have worse outcomes with lower tidal volume. I mean, you commented that it was really only a small group. Just curious, is that an effect that could potentially be rescued by using PEEP?
Thank you so much. This is an excellent question. We also need to look into that. So I would say we were not powered enough to present findings related to this small group of patients, but definitely it's intuitive for future studies to be conducted on this. And I think since we concluded a definite mediation analysis with the 100% of driving pressure, PEEP could play a role, a significant role in these patients. Definitely.
Okay. Well, thank you again. Fantastic presentation, great work, and congratulations again on your award. Thank you. We'll be moving on to our next award. The next presentation is by Dr. Johnny Kenth from the Royal Manchester Children's Hospital in Manchester, obviously. He is receiving the Junior Faculty Pediatric Anesthesia Research Award for his work. Take it away, Dr. Kenth.
My name is Dr. Johnny Kenth, and I'm delighted to be invited to present the findings of my MSc dissertation in health data science, looking at the incidence and risk factors of perioperative respiratory adverse events in children undergoing surgery by employing logistic regression machine learning exemplars. So I'm a consultant paediatric anaesthetist at the Royal Manchester Children's Hospital and honorary senior clinical lecturer at the University of Manchester with an interest in data science. With full disclosure, I have no financial or commercial interests. I have, however, received grant funding by the National Institution of Health Research and the Mucopolysaccharidosis Society. Perioperative respiratory adverse events, PRE, are a common cause of morbidity and mortality in children, accounting for over 3/4 of critical adverse incidents during the perioperative epoch. PRE include laryngospasm, bronchospasm, hypoxia, airway obstruction, stridulous breathing, persistent coughing, atelectasis, and the need for continual oxygen requirement in the early postoperative period. Risk factors have long been known for PRE, and these include having an intercurrent upper respiratory tract infection, respiratory past medical history such as asthma, COPD, chronic lung disease, and having a history of atopy. The prevalence of PRE is thought to be 8 to 15%. And why is this important? Well, based on World Health Organization global modelling studies, it's estimated 50 million children a year undergo surgery. That's across the world. In the United States alone, 6 million children undergo major surgery, many more for general anaesthesia. 25% of these are infants. And if 15% of these develop PRE, this is a significant and serious incident which we as anaesthesiologists should be mindful of and tailoring our anaesthetic to prevent these PRE outcomes from occurring. So looking at a timeline of PRE, so since the 80s, PRE has been well recognised. It was thought to be as high as 53%. During the early 2000s, single studies looked at the incidence and frequency of PRE being approximately 8%. However, these studies were found to be small observational, confounded by bias, and not very rigorous. In 2010, Professor Britta von Ungen-Sternberg undertook the first landmark study really addressing this research question, and her follow-up study identified having 4 risk factors was highly statistically associated looking at PRE. And this was a really rigorous study and was the foundation for my MSc dissertation. Subramanian et al. Developed and validated clinical risk prediction modelling, and they found composite 3 PRE outcomes to be about 3%. However, they follow a rigorous methodology such as tripod and the steps of validating risk prediction modelling by Steinberg. Our study objectives was to ascertain what the perioperative risk factors for PRE were, as this was a data science project. And wanted to undertake visualization wrangling in a rigorous and methodological manner, explore how missingness was important, how to deal with missingness, and finally whether classical statistical approaches compared to machine learning approaches. Our strategy for data analysis includes data visualization, dimensionality reduction, univariate, multivariate analysis, and machine learning. Data wrangling, this followed the 6 steps of data wrangling, including sourcing the data, so 2 data sets. I then looked at combining the 2 data sets and whether variation between them and within the data sets made that appropriate by undertaking t-test chi-squared. I undertook histograms, QQ plots, and correlation tests. And this was important later in multivariate analysis to rule out multicollinearity. Missing data was a real important part of this project. 5% of children had missing data, and we found this missing data, the underlying mechanism was missing at random, so it was appropriate to use multiple imputation using multiple chain equations. We compared this to K nearest neighbour and found they were non-inferior to each other. Dimensionality reduction included principal component analysis, which helped reduce the number of candidate predicted to initially 22. Univariate analysis involved correlation, regression. Correlation was both Pearson and Spearman, and regression involved using a single candidate prognostic factor and using a binary outcome of PRE or not. Building upon our univariate analysis, we did a multivariate analysis, and we undertook model calibration, validation, looked at the area under the receiver operating curve, and then we plotted calibration plots and Hosmer-Levenshaw chi-squared tests to scrutinize the statistical difference between the observed and expected values. We then calculated a minimum sample size, which was 165, based on the population incidence of PRE, and then we followed the 9 steps for developing an internal validation in a rigorous manner for clinical risk prediction modelling. For machine learning, we undertook both supervised and unsupervised machine learning algorithms. This included cluster analysis. And then for supervised machine learning algorithms, this included support vector machines, decision trees, gradient boosting, and neural networks. Our data set included demographic data such as age, sex, procedure. In terms of class harmonization, data standardization, it took a lot of my time spent cleaning the data set, recoding things, making the data applicable and easy to use in Python and RStudio. Respiratory history, including whether the patient had a cough, a runny nose, past medical history of obstructive sleep apnea, asthma, anaesthetic drugs we looked at, and then the LMA size, type, whether there was a leak, whether it needed to be changed. We also looked at LMA factors such as when it was removed, what position the patient was in, and factors that were correlated we collapsed into a single, for example, position. And then finally, our outcome measure was prey features such as desaturation, coughing, laryngospasm, and bronchospasm. That was a binary outcome. Moving on to our findings, we found that preoperative factors such as age and weight was highly statistically significant. Presence of cough, both dry and productive, rhinorrhea, fever, which is the highest independent risk factor we found. Past medical history of asthma and other respiratory disease, such as obstructive sleep apnea. There were 3 or 4 which we collapsed into a single outcome. And then we looked at removing the LMA, which was deep removal found to increase your odds of getting a prey outcome, suctioning the airway prior to removal of the LMA, and presence of blood and secretions in the airway. This is what my logistic regression equation looks like. So to test our model, we undertook a confusion matrix, which is an n by n matrix, and then plotted a ROC curve and found we had a really good performance by splitting our data and then testing our equation with data that wasn't involved in the development of the logistic equation. And we found the area under the curve was approximately 85%, which showed good performance. In terms of machine learning algorithm, we use K-medoid, which is better for mixed data, which is categorical and numerical data, and is less sensitive to outliers. And immediately what became apparent was cluster 4 were the only children that had adverse outcomes or any prey outcomes. And these children tended to be younger, tended to get airway surgery, had a history of a cough with a past medical history, such as asthma, were more likely to have given a pre-medication with a drug such as midazolam, and they're more likely to have a poor fitting LMA in the first instance, which required sizing up. They were likely to require oxygen therapy. They were likely to develop laryngospasm. So this really reinforced what we found in our logistic equation. And this is what a K-medoid clustering analysis showed, and it's really here apparent that this is different from the other clusters. The K-medoid would have a central medoid with, then we look at distance from the central medoid, and we used Euclidean distance. How did our model compare for logistic regression compared to other machine learning exemplars? Well, it performed the best. We looked at, this is a summary of a confusion matrix looking at sensitivity, specificity, accuracy, and the area under the ROC curve, which is a C statistic or concordance statistic. We found support vector machines performed 11% worse, decision trees 13% worse, gradient boosting 14% worse, which is surprising because gradient boosting has long been lauded as one of the more superior machine learning algorithms. And finally, neural networks, 8%. Full disclosure, this is one of 100 neural networks I did using different algorithms. Finally, in conclusion, the study found that the predictors of prey were consistent with previous studies. However, we also recognised new factors such as suctioning of the airway and pre-medication may increase the risk of prey. We conclude that identifying risk factors of prey can help improve informed decision making and help tailor the anaesthetic conduct to help alleviate risks. We also introduced a new dimension to analysing data from retrospective quality improvement data sets in a rigorous methodological manner by paying meticulous attention to data quality and completeness. This underscored how a data-driven epistemological approach can synergistically work with a priori hypothesis-driven research. Thank you very much.
Excellent. Thank you. Thank you so much for that presentation, and congratulations again. Definitely invite the audience to ask questions, specifically the data scientists out there. I have a question by Dr. Plana. Was suctioning actually a surrogate outcome? Could the underlying cause have been increased secretions or poor secretion handling? Oh, you're muted.
That's an excellent question. What I found, and this was really interesting, was not suctioning in those individuals who got prey. It was more significant. And what we found, it wasn't a surrogate marker, but not suction did increase. In children you think are going to get a composite prey, suctioning helped reduce the relative risk, or in this case, the odds of getting composite prey outcome we found. And that hadn't really been described in the literature before. So I thought that's quite interesting.
Thank you. If I understood your approach correctly, I mean, you were feeding some of your risk factors into the model, correct?
So can you just say that again?
How did you identify the risk factors that you were feeding into your model? How did you agree on those?
So I initially started with the data sets, 2 data sets, bringing them together. I then did univariate analysis and see which were significant. And then I entered them into a multivariate analysis using logistic regression, and also compared it to using some Poisson distribution. And what we found was, as all the complications were highly statistically correlated, we collapsed it into one odds ratio, which is a binary outcome of composite prey and not composite prey. I then essentially used a tripod guidance. So there's quite a lot of risk prediction modeling in anaesthetic literature at the moment, and few of them actually follow things like tripod. And I was quite lucky that my supervisor at university is one of the experts in this area. So I almost use this as a scalability study, that if we were to do this as a big national project, how we would do that.
Were you surprised by any of your risk factors? I mean, they seem to align quite well with what experience, if there is such a thing, would suggest.
Yeah, the cluster analysis was really shocking, because it was really clear the one that got complications. And by doing cluster analysis, you can kind of see what these, on average, what features these children would have. And I thought that was really interesting, because I thought the data will be a bit muddled. It's quite a small data set. Machine learning really likes big data, like thousands, tens of thousands. But I thought in such a small data set of 326 individuals to get that significant kind of clustering was really fascinating. And so, same with support vectors. With support vector, you've got binary outcome of prey, not prey, and then you create a hyper plane. Again, it was really interesting. So yeah, really reinforce the literature, and hopefully I would like to do this as a bigger study, as a multi-centered study.
Yeah, absolutely. Do you think, did we get lucky? Are we just that good clinically that we really know our risk factors, or is there just that tight of a correlation in the pediatric population between the complication and the risk?
Yeah, I think there has been a lot of excellent work. So again, Professor Britta von Ungenberg, her work was fundamental, and she'd talked about this over the last 10 to 15 years, and she has done a lot of work, which I think was really interesting. What I showed was using her research question is with a novel approach in terms of using machine learning and more advanced data modeling techniques.
Okay. Great, thank you. I have another question by Dr. Studiv, wondering whether LMA is the standard airway for children in the UK for most surgeries.
I think it depends on the surgery. I only looked at surgeries with LMA because I had that data set, and that's why we only looked at LMA surgeries. And these are usually quick procedures under an hour. and often quite straightforward procedures, elective surgery. And to have pre-outcome that high, I thought quite interesting, because I thought it'd be quite lower. What would be really interesting in the prospective studies, we then compared it to endotracheal intubation. The only caveat there is if children are being intubated, they may be sicker, they may be having emergency surgery. So we may not quite be comparing apples and oranges there.
Yeah, introducing more confounders. Okay, excellent. Well, thank you again. Congratulations. We are moving on to our next presenter, next awardee, Dr. Michael Burns from the University of Michigan, where he is an assistant professor. Dr. Burns is the recipient of the Junior Faculty Perioperative Medicine Research Award. Congratulations, and let's move to your talk.
Hello, everyone, and thank you for coming. I'm excited to talk to you about the association of anesthesiologist staffing ratio with postoperative morbidity and mortality. My name is Michael Burns, and I'm an anesthesiologist from the University of Michigan. For disclosure, I'm a co-investigator on project funding for Blue Cross Blue Shield of Michigan and the Patient-Centered Outcome Research Institute. Anesthesiologists provide overlapping care to between 1 and 4 surgical patients or cases simultaneously. Staffing ratio is the ratio of an anesthesiologist to the overlapping number of rooms they cover. And it's important to consider this ratio as it drives faculty needs, workforce size, and practice reimbursements. Additionally, there remains cost reduction pressures to increase staffing ratio, given the ability to reduce faculty costs with stable reimbursements. In our studies, the staffing ratio was calculated for each individual case from all cases prior to the application of inclusion and exclusion criteria using a time-weighted average. For example, if there exist 2 simultaneous cases covered by the same anesthesiologist, 1 2-hour case and 1 1-hour case operating in parallel, the staffing ratio of the 1-hour case is 2, and the staffing ratio of the 2-hour case is 1.5, as half of the case was operating with an anesthesiologist covering 2 cases and the other half covering 1. The primary outcome of the study was a composite using mortality and 7 perioperative morbidity complication categories defined by ICD diagnoses: cardiac, respiratory, gastrointestinal, urinary, bleeding, and infection. Data was obtained from the multicenter perioperative research group electronic healthcare data registry from January 1st, 2010 to October 31st, 2017. This data focused on adults undergoing elective surgery from general, gynecologic, neurologic, ENT, orthopedic, urologic, and vascular operative groups. We excluded cases covering fixed staffing ratios, including cardiac cases, liver transplant, cataracts, obstetric cases, and those with residents signed into greater than 25% of the case. Cases missing anesthesiology, CPT codes, and overnight cases were also excluded. We used propensity matching to compare similar cases, matching within each surgical group and adjusting on patient, procedure, and hospital level confounders. We were able to create 4 balanced sample groups defined by staffing ratio. A staffing ratio equal to 1 is where an anesthesiologist was covering a single case for the duration of that case. And we have separate groups with coverage between 1 and 2, 2 and 3, and 3 and 4 overlapping cases. Using the staffing ratio 1 to 2 group as reference, 3 propensity score models were developed for the remaining groups. Over 800,000 cases were identified from nearly 2,000 anesthesiologists across 23 distinct institutions. Following propensity matching, the resulting data set consisted of greater than 500,000 cases. The final match sample shown here is a fairly balanced distribution of confounders between staffing ratio groups, as well as with respect to the original distribution of the pre-match sample. We used a standardized difference to assess for imbalanced distribution of confounders between groups. A value of greater than 0.2 is considered large and suggests imbalance. The only factors indicating potential imbalance were the case occurring at a teaching institution at 0.26 and anesthesiology duration at 0.34. We adjusted for these variables in our models that we use to create adjusted odds ratios, as you'll see in the next few slides. The individual outcome categories are each well represented in the composite between 0.66 and 1.16% prevalence. The overall composite existed in 5.39% of cases in the matched data set. We fit a multivariable conditional logistic regression model for our primary outcome, adjusting for staffing ratio, age, sex, BMI, ASA status, emergency status, anesthesia technique, anesthesia CPT group, number of Elix-Hauser comorbidities, surgical service category, anesthesia duration, and whether or not the procedure occurred in a teaching institution. We use this model to calculate an adjusted odds ratio for each staffing comparison, and we use the adjusted odds ratios and the rate of the reference group to calculate adjusted event rates. This graph here represents the adjusted rates for each staffing ratio group and shows a significant increase in adjusted composite morbidity and mortality rate for staffing ratios between 2 and 3 and ratios between 3 and 4 relative to the 1 to 2 reference. This table shows the adjusted odds ratios for each staffing ratio group. Odds ratios greater than 1 mean higher odds for a morbidity mortality composite outcome as compared to the 1 to 2 reference group. From this table, you can see while the staffing ratio equals 1 versus 1 to 2 is not significant, the bottom 3 comparisons are. So compared to patients receiving care from an anesthesiologist covering between 1 and 2 cases, patients exposed to an anesthesiologist covering between 2 and 3 and 3 and 4 overlapping cases demonstrated a higher risk of adjusted odds of morbidity and mortality, where 2 to 3 overlapping cases had a 5% increase and 3 to 4 overlapping cases, 13%. Despite treatment bias for healthier patients and lower risk procedures, higher overlapping anesthesiologist coverage is associated with higher surgical patient morbidity mortality. And these findings highlight potential effects of anesthesiologist responsibilities in the perioperative team models and should be considered when considering clinical coverage efforts. So with that, I thank you and I welcome any questions either by email or in person.
Very nice. Thanks a lot. And once again, we're open for questions. I'm curious, how did you select the complications that went into your composite endpoint? I'm wondering about specifically infections and bleeding and the potential causal link between anesthesia staffing ratios and those.
It's a very interesting question. So we had to focus on complications that could be potentially attributable to anesthesiologists, which is hard. It's a very difficult thing to do. So we used ICD coding in perioperative outcomes. We created phenotypes around these ICD codes that are specific for perioperative related complications. So while it's hard to definitively say that it was an anesthesiologist induced complication, these are the cohorts we chose.
Okay. Got a question from Dr. Fritz. Did you consider the time of day? Were the higher ratio cases more likely to be emergent or after hours?
We limited our studies to between operative hours of 7 a.m. to 7 p.m. to try to reduce the variability in staffing ratios. Because you can imagine, if, as you saw with the staffing ratio equal to 1, that group was not statistically significant. And it makes a lot of sense to me and our group that you may be staffing ratio 1-to-1 based on the acuity of the case, but you may also be 1-to-1 based on the flow of the operating rooms, maybe down to 1 operating room and covering 1. So we wanted to reduce that variability by limiting holidays, nights, weekends, that sort of thing.
Okay. Dr. Sedensky is wondering about the exclusion criteria in relation to resident physician involvement and whether you could explain that again.
Yeah, it's an excellent question. So we really wanted to open it up to the perioperative care team model. And if you have a resident involved due to reimbursement practices, there is often a limitation of 1-to-2. So we wanted to be able to look at staffing ratios between 1-to-1 to 1-to-4. So reduce that, we omitted cases and associated cases that had greater than 25% involvement by a resident.
Okay, thank you. Dr. Evenson's complimenting you on an interesting talk and is wondering how this could be compared to cases where solo CRNAs were used and whether you have any data for solo CRNA cases.
Yeah, unfortunately, in our data set, we do not. And we also don't have data for anesthesiology assistants. And we're limited in data beyond a staffing ratio of 1:4. So those are all good questions and merit further study.
So roughly what percentage of cases in your database were you looking at with excluding residents and higher ratios? How substantial of a portion of the pie is this?
Well, including all exclusions, we found that about 800,000 cases met our criteria. And after we matched, we lost about 300,000 cases. So we ended up with, I think it was 570,000. Yeah. And again, we were matching on a lot of potential confounders because we wanted to make sure that case A that was matched with case B were as similar as possible in terms of the case and the patient characteristics.
Understood, yeah. Dr. Zdensky is asking whether seniority or experience of the anesthesiologist was a factor.
It was not in our study. It's very interesting and it'd be great to look into something like that, but we didn't have the data on hand. So as of now, no.
Okay. And I mean, understanding that MPOC obviously is an anesthesia database, but given the surgical role in complications, do you have any way of assessing for I guess, surgical involvement versus, I guess, at teaching hospitals, the split between attending surgeon versus trainee surgeon time in the case?
Correct. That's another interesting point. We did not focus on the trainee versus attending or their familiarity with the cases. That's that would be an interesting study for the future.
Okay. Any additional questions by the audience or the panel? Excellent. Thank you. Thank you very much again. Very exciting work. Moving on to our last talk by Amy Tsai from UC Davis. Her presentation was selected as one of the top oral abstracts of the meeting. So we'll hear her talk.
Thank you all for coming. Today I'll be talking about integrating single-cell and plasma proteomics in order to predict surgical site complications. My name is Amy. I'm a fourth-year med student at UC Davis, and I'm presenting my research with the Godelier Lab at Stanford School of Medicine. I have no financial disclosures. Complications occur approximately 1 in 5 surgeries, and that means of 110 million surgeries performed each year in the US and in Europe, that comes out to 22 million complications. Of that, 2.2 million are surgical site complications, and that translates to prolonged personal suffering as well as significant socioeconomic burdens in the form of longer hospitalizations and readmissions. However, postoperatively, a patient's recovery trajectory is complex. And despite very similar demographics, baseline health metrics, as well as patients undergoing very similar surgeries, the development of surgical site complications can vary quite drastically. While current risk prediction tools based on clinical parameters are really accurate at predicting risk of mortality or discharge to a SNF, they're not sufficient at estimating an individual patient's risk for surgical site complications. For example, the current surgical risk calculator, NISCIP, predicts surgical site infections with an AUC of 0.7. For other complications, such as pneumonia, UTI, readmission or reoperation, aggregate complications, it is not an adequate predictive tool, so an AUC of less than 0.7. As such, perhaps we can integrate the biological parameters that drive the pathogenesis of surgical site complications in order to increase risk prediction accuracy and improve patient care in the long run. So surgery triggers a profound and highly coordinated immune response that engages innate and adaptive immune compartments. This involves both pro and anti-inflammatory or pro-resolving processes for pathogen defense, tissue remodeling, and the resolution of pain. Within minutes of surgical injury, there is activation of the inflammasome that leads to a TLR activation by DAMPs, and this results in the secretion of pro-inflammatory cytokines such as IL-1 beta, IL-6, and TNF-alpha. IL-6 in particular activates the STAT3 pathway and has been shown to forecast adverse postoperative outcomes, such as onset of delirium as well as mortality. Simultaneously, there are anti-inflammatory and immunosuppressive adaptations. Now, dysregulation in either direction increases the risk of postoperative complications. Overt pro-inflammatory immune responses can lead to SIRS, while profound postoperative immunosuppression can predispose a patient to developing post-surgical wound infection or bacterial sepsis. Other complications can also arise as pro-inflammatory and immunosuppressive responses tilt out of balance. Immune response to trauma is very well orchestrated. It involves all branches of the immune system and engages virtually all immune cells. So therefore, it's very important to be able to study the immune system at a single cell level and understand the function and role these cells play in the development of adverse outcomes. Luckily, we're able to do this with mass cytometry, which allows for the simultaneous interrogation of all major innate and adaptive immune cell types using 50 phenotypic and functional markers. Mass cytometry is very similar to flow cytometry, except it uses lanthanide and other heavy metals rather than fluorophores. Without the risk of spectral overlaps, CyTOF is able to measure many more parameters per single cell. To give you some background, we collect whole blood samples from a simple blood draw. These samples contain red blood cells, which we lyse prior to analysis. And once we've isolated the leukocytes, we barcode them with a 6-3 combination of unique palladium isotopes. This allows for the simultaneous study of up to 20 samples per plate and minimizes experimental error. The samples are pooled and stained with these heavy metal conjugated antibodies and then analyzed using mass cytometry. So what kind of information can CyTOF give us? Well, first of all, it can identify all these innate and adaptive immune cell subsets and quantify their abundance. We can then study the function of each of these cell populations, looking at their endogenous activity or how they respond to cytokines such as LPS, interleukins, and interferon alpha. We can then form a network of these immune cell features in order to holistically understand how the immune system responds to certain immunological triggers, such as surgical trauma. So we use this tool with the goals of improving predictive performance. We hypothesize that single-cell and plasma proteomic elements of a host's immune response to surgery can accurately identify patients who will develop a surgical site complication after major abdominal surgery. So 41 patients undergoing non-cancer bowel resection were prospectively enrolled. 11 patients developed surgical site complications as defined by a surgical site infection, anastomotic leak, or wound dehiscence within 30 days of surgery. Blood samples were collected at baseline, before surgery, as well as on postoperative day 1. The whole blood samples were either left unstimulated to study the endogenous activity or stimulated with cytokines. These samples were then analyzed using mass cytometry, and in parallel, the plasma concentration of 272 proteins were quantified using Olink. So mass cytometry produces a high-dimensional data set due to the very complex and interrelated processes that require advanced machine learning methods. So in simple terms, we create elastic net models for each of the 9 data layers in order to predict the development of surgical site complications. We then integrated all of these models and using a stack generalization method and yielded a final predictive model. This model classified patients with a high accuracy, an AUC of 0.86, and remains significant when accounting for patient group differences in age, BMI, sex, surgical duration, or the use of biologics. So delving into the biology, let's examine a couple features identified by the model. So certain pro-inflammatory proteins were elevated in patients who develop a surgical site complication, including STREM1, which is an enhancer of the TLR4 pathway, as well as LIF, which is an IL-6 family cytokine. Other proteins were decreased in patients with surgical site complications, including EIF5A, which is implicated in T-cell activation and autophagy, as well as KRT19, which is involved in epithelial cell differentiation, particularly of the colonic mucosa. And this suggests that patients at risk of surgical site complications may have impaired healing. I'd also like to highlight a couple specific immune cell features. So using VOPO, this is an unsupervised clustering algorithm used to agnostically map and visualize the single cell proteomic data set. Major immune cell subsets were identified based on phenotypic markers, and then their functional responses were studied in more detail. Consistent with prior findings, STAT3 activity in classical monocytes is activated in patients who develop a surgical site complication. Remember that the STAT3 pathway is activated by IL-6, and coupling this with the elevated LIF levels in patients with surgical site complications, this suggests that activation of canonical pro-inflammatory pathways is more pronounced in patients who will develop a surgical site complication. Additionally, the abundance in STAT3 signal was elevated in the immunosuppressive MDSCs, and this indicates that an unchecked systemic activation of anti-inflammatory cells in response to surgical site injury may also contribute to the development of a complication. This is also reflected in the adaptive immune branch with elevated STAT5 activity and regulatory T cells. So in summary, the complex interplay between pro-inflammatory and anti-inflammatory mechanisms after surgery differed between patients with and without a surgical site complication. This difference is detectable as early as 1 day after surgery and is harmonious with current theories on surgical site complication risk factors. However, we had these baseline samples and we wanted to ask the question, can we predict if a patient will have a surgical site complication before they even get the surgery? And the answer is yes. So we applied the same analysis algorithm to the baseline samples collected before surgery. And the ability to subject these immune cells to exogenous cytokines and simulate an inflammatory setting proved to be effective. The resulting model accurately differentiated the two patient groups with an AUC of 0.82. Our latest model, which actually integrates parameters from the ACS risk calculator, improves this performance to an AUC of 0.94. Now, this allows for promising interventions prior to surgery, such as prehabilitation. In our current clinical trial, patients are recruited and enrolled in a rigorous 3 to 6 week prehabilitation program in which their fitness, nutrition, meditation, as well as cognition are optimized. Preliminary data has shown improvement in surgical outcomes. Of course, this study is subject to a couple limitations. For example, the two patient groups did differ with respect to known risk factors for surgical site complications, including BMI, surgical duration, and EBL, all of which were elevated in patients with surgical site complications. Additionally, our patient population included IBD patients who were undergoing immunomodulatory therapies, such as TNF-alpha inhibitors, which may have influenced their immune response to surgery. However, post-hoc analysis show that our predictive models remain significant even when accounting for these confounding variables, which suggests that differences in the immune system between these two arms are not predominantly due to clinical or demographic risk factors. Mass cytometry is currently limited to approximately 50 parameters, which means that smaller and novel immune cell subsets may have been precluded from the analysis. Lastly, we did not assess a local immune response, nor did we measure the differences in the patient's gut microbiota, which obviously will be important in determining the relationship between local and systemic immune events that are associated with surgical site complications. So in conclusion, CyTOF analysis revealed key immune responses that mediate important adaptations in the development of surgical site complications. Multivariate analysis produced models that are more predictive of surgical site complications than the current gold standard. These models remain significant when accounting for confounding factors. And lastly, this is a promising avenue for guiding preoperative interventions or prehabilitation, or for guiding surgical timing. Finally, I would like to acknowledge the amazing team that helped make this study happen. Dr. Christy Rumer is a colorectal surgeon now at Cleveland Clinic, and Julian Hadou ran the analysis for this study. Additionally, we had an amazing panel of senior scientists, Dr. Bourlier, Dr. Kin, Dr. Ongs, and Dr. Gayapur, who all contributed to this study. And lastly, I'd like to thank all of the lab members who also contributed in this study. And thank you all so much for listening.
Well, that was a really elegant study. My thanks to Dr. Tsai. Unfortunately, she has not been able to join our session today, so we will not be able to answer her questions live. She does have a poster presentation as well, so feel free to post questions to her at her poster. We have a few minutes left in the session, so short of questions to Dr. Tsai, if anybody has any remaining, excuse me, questions for the rest of our panel or any comments they would like to share, please take advantage of the remaining minutes. And in the meantime, I definitely want to, excuse me, I definitely want to congratulate and thank all of our panelists and presenters. Once again, I think this was a really, really exciting session. I think this one and the session we had yesterday really gave us a very, very nice overview of the breadth and the depth of anesthesia research that is going on currently, and is plenty of reason to be excited. Thank the audience for joining, for raising questions to support the further refinement of our presenters' studies. And I definitely would encourage you all and invite you all back to this afternoon's final SAB session. We have another parallel oral abstract session that is concluding our meeting today at 6:30. So please come see more exciting science and support our scientists in the field.